Luckily, pancreas transplant is one of the few organs where the wait list is not so very long. So people can be transplanted with the pancreas in a relatively short period of time. Again, I'm quoting the Diabetes Control and Complications trial, and the point is, we already know that if you can become euglycemic and remain euglycemic, that is a huge benefit for lifestyle and as well as life. You will live longer and you will have less complications if you can remain euglycemic. This is something a pancreas transplant can do. However, there are risks involved because it is it's a big operation, and that's why islet transplantation becomes so very attractive. If you could not undergo a big operation and just have injections of these cells, and these cells will now do what your pancreas, or at least the endocrine function of your pancreas, which is where all the insulin comes from, then that's a huge benefit. And again, there's a lot of research going on in that area, including here. So the optimal goal will be low morbidity and mortality, that you could undergo an operation or an injection and that your risks are going to be low, that you no longer need exogenous insulin or need very little of it, that you eliminate hypoglycemic events. Again, this is very dangerous to people that have been diabetics for a long period of time. You get this euglycemic state and you sustain this over time. Islet transplantation is very young, in at least successful islet transplantation, which really started in Canada, the Edmonton Protocol. Around the year 2000, this data came out. It was published in the New England Journal, and everyone became so excited because they figured, okay, here we have it. Islet transplantation is going to be the future. The problem is that in Edmonton or in Canada, unlike here, they don't do a lot of solid organ pancreas transplants. So they were taking mini grafts. So, 3 or 4 patients would die. They would take the pancreata, chop them up, take out the islets, and then inject them into a patient. What they proved was that indeed it could work. What hasn't happened, it's not durable. In other words, it only works for a short period of time. Most of the patients that received islet transplants by the Edmonton Protocol were back on insulin within a year, and they were back to their normal dosages within 2 years. So it hasn't proven to be durable. However, it was proof of concept, and that's why here in the United States, a lot of money was set forth by the government to push for islet transplant programs around the country. They do exist. However, you need to be enrolled in an experimental protocol, and unfortunately the outcomes have not improved markedly over what they already had found in the Edmonton Protocol. I think it's the future, but at present it is not something that's going to be available for most Americans. So this is your pancreas, and the little blue dots are the islets. So most of your pancreas is not concerned with insulin production. Only those little blue dots is where the insulin comes from. So 99% of the pancreas is actually important in digestion. So those cells are making enzymes for digestion. Funny as it may seem, we can actually give you the enzymes today. So all of those enzymes are available, and if you had your entire pancreas cut out, all you would have to do is take by mouth the enzymes every day before you eat, and you don't really have a problem with digestion because of that. People often ask me, well, do diabetics have problems with the exocrine? And usually they don't. So most diabetics, although the little blue areas in the pancreas are not functioning properly, the rest of the pancreas is functioning fine. So exocrine function of the pancreas is usually not a problem in diabetes, unless your diabetes is secondary to pancreatitis, which is not the case for most people. So it is kind of ironic that such a small portion of the pancreas causes so much of a problem. Diabetes, at least autoimmune diabetes, type 1 diabetes, is when your body attacks those little blue areas. And those tissues are very different from the rest of the pancreas. They kind of merge when we're being developed inside the womb. But it's those little blue areas that we try to replace in islet transplant as well as pancreas transplant. So I will transplant that entire organ in order to get the function of just those little blue areas. And this is the way we do the transplant. We make an incision in the abdomen and we will transplant the pancreas and a small segment of intestines that comes from the donor. Once inside the body, we will connect the intestines to your intestines, and then we attach the blood vessels from the donor pancreas to the vessels down in your pelvis. Very similar to the way we do a kidney transplant. Again, the most common type of pancreas transplant is when you receive a kidney and a pancreas at the same time. So this is a diabetic patient who has kidney failure. We will get both organs from the same donor, and we will make an incision right down the middle of the abdomen. We'll put the kidney on one side and the pancreas on the other side. This is the most successful type of pancreas transplant, and these patients, after their operation, are no longer on dialysis and they're no longer on insulin. So you get rid of both problems at the same time. Now, of course, they have to take medications to keep them from having rejection, well, for the rest of their lives. But they get both organs at one operation. And again, the history of pancreas transplant started in Minnesota. Outcomes were not very good. What really turned in good in the outcomes was the development of new medications. Cyclosporin, which was actually a medication that was developed as an antibiotic, which came to the United States in the 1980s, proved to be a very strong immunosuppressant, and it decreases your lymphocytes. It was the discovery of cyclosporin that really revolutionized the field of transplantation, and of all organs, and including pancreas transplant. So the outcomes got much better once we had better medications, and our medications have gotten better still since the 80s. So that's why the outcomes have improved so much, along with the fact that we've learned a lot over the years, and our surgical techniques are much better. So now we do a lot more pancreas transplants, and as you can see, again, the most common type is going to be, in green here, are simultaneous kidney and pancreas. The blue bar is pancreas after prior kidney transplant. So someone came in, they got a kidney transplant, and then they came back and got a pancreas transplant. And then you have pancreas transplant alone, which is the least common, but it's becoming a more commonly done operation. And here are the outcomes. The outcomes have improved markedly. What you can see here is that 3-year survival for patients that receive a pancreas transplant alone is about 95%. And if they received a simultaneous kidney and pancreas or a pancreas after kidney, then they're right about 90%. That's patient survival. You might wonder why pancreas transplant alone has the highest. You have to realize these are the healthiest patients. These are patients that do not have kidney disease, and they tend to be in very good condition. When you look at the survival of the graft, however, the pancreas graft survival is best if you receive a kidney and a pancreas at the same time, and that's about 85% at 3 years. But still, for any type of transplant, it averages out to approximately 70%, which is much better than what used to be the case even a little over a decade ago. So the outcomes have improved markedly. But I will tell you, it's still a large operation, and it can be unsuccessful as well. Patients can die after transplant, and they can have graft losses as well. So the only way you're going to get this euglycemia, at least the only way you're going to get it with what's available today, would be a pancreas transplant. No form of insulin therapy is going to make you euglycemic. There's always going to be peaks and valleys, even when your hemoglobin A1C is quote-unquote normal. And that's what, going back to the case report, that's what was happening to this lady. There are going to be a percentage of patients that are going to continue to have secondary complications of diabetes with the best insulin therapy there is available. If you look at cardiovascular disease and peripheral vascular disease after pancreas transplant, most studies have concluded that these vascular diseases will stabilize after transplant. So it's not that they really improve much, but they stabilize. One of the problems with diabetics, particularly young diabetics, at least a subset of them, is that they can have heart attacks at very, very young ages and have a profound peripheral vascular disease. I always tell my patients there's no quicker way of getting an amputation than combining diabetes and smoking. So no diabetic should ever be a smoker. But it's a horrible for your vessels to combine smoking and diabetes. It's like Russian roulette. And I'm sure we have no smokers in here, right? Yeah, nobody's raising their hand. Oh, you are a smoker?
No, I just had a question. You made a distinction between two types of surgery, one that involves grafts and then called it pancreas. What's the difference? What does the graft mean?
Yeah, well, the graft means deep pancreas. So when you start talking about survival, you have survival of the patient, and then you have survival of their grafts. When you get a kidney pancreas transplant, you're getting two grafts. You're getting a kidney graft and a pancreas graft. So one of the things that happens when you get a kidney pancreas transplant, the pancreas actually protects the kidney. So if you take a diabetic and you give them a kidney transplant versus giving them a kidney pancreas transplant, and then you look at graft survival, kidney graft survival is going to be better in the diabetic that got both organs versus the diabetic that only received the kidney. Okay? But patient survival is something that's different. Patient survival tends to be a little bit higher than any of the graft survival because there's going to be a small percentage of people that will have gone through an operation and their grafts may have functioned for a short period of time, and then they lose them, but the patient is still alive. That's why patient survival is always better than graft survival. Looking at neuropathy and gastropathy, although gastropathy really doesn't get better after the operation, most people that have that type of problem, it's really not going to get better. So people, and we should put a coloparesis under this as well. Some diabetics, with time, they have problems with nausea, vomiting, and things of that nature. That really doesn't get better. Same thing with people that have a lot of constipation because of what the diabetes has done to their nerves over the years. The good news, however, is neuropathy. Neuropathy can get better and get profoundly better. I've had many of my patients that I've done pancreas transplants upon who neuropathy totally will go away, and sometimes it's very quick within months of the operation. So neuropathy can improve. I'm not saying everyone's neuropathy will improve, but neuropathy is one thing that really improves, and even erectile dysfunction can improve. And that's one of the things I always like to tell my male patients. Gets them to sign up very quickly. Retinopathy does not. It doesn't improve, but it does stabilize. So retinopathy does stabilize. And that is important because, these patients oftentimes will have had numerous laser operations and maybe progressively losing their sight. So although it doesn't improve, it will stabilize. Nephropathy, actually, one of the nephrologists at the University of Minnesota wrote a landmark paper in 1999 where he went back and looked at a lot of these patients that had received pancreas transplants for diabetes that had some degree of kidney disease. They either had nephropathy, meaning that they were spilling lots of protein in their urine, or they actually had increased creatinine, not to the point of needing a kidney transplant, but they did have kidney dysfunction. After about a year, and he